the first thing I'll start out saying is that you should use extreme caution with what you put on Facebook, even if it's your closed Facebook page, because ultimately anything is subject to being propagated, right? That means anybody can end up seeing something you don't intend them to see. So that's just a generic warning, because your professionalism can still be scrutinized based on something you put up that can be viewed by somebody else. So I would strongly urge you to be careful what you say and how you say it, and who you say it, because you never know. And I know that if I get objective evidence in the future of anything that is unbecoming, I have no problems really coming down on it, because I, as a human being, as a person, as a PA, as a member of this community, do not tolerate unprofessional. So don't do it. That's your warning. After that, I will not hold back. So, how was the midterm? Yeah. The final will be cumulative. There'll be some stuff on there. I haven't yet come up with what the distribution, the percentage will be. Probably 20% from the first half and 80% from the second half. That's what I'm leaning towards now. So, Thursday I won't be here. I won't be in the building Thursday, Friday, and Monday. So accordingly, we won't have class. We won't be Thursday, and I think we're scheduled for Monday, but I don't think I'm planning on having it Monday. So I won't be in the building Monday. And then tomorrow I'm at the IC, so I won't be here tomorrow. So if you want to meet me or ask me about anything, today is your day. I'll be here. I'll be here until probably, I'm guessing, 5 o'clock, and then I'm back in the IC tonight again. So with this, there's a good amount of material. I'm not sure how long it'll take me to get through it, but what I'll ask you to do is, if you have questions, write them down. We'll try to do it at the end, and once we get to the end, we'll see where we are. We'll see how it goes. It's a lot of material, but I assure you that I don't expect you to memorize every bit of minutia. I think that you should now get a sense of what my style is for this course anyway, in terms of the final's going to be similar. I will, if you bother to pay attention to me, I will stress to you what I really, really want you to take home. There's a lot of details, like all these different causes of hypokalemia and all that. I will give you what it is that I would expect you to have as baseline knowledge entering rotation, understanding that you will be looking this stuff up again. I know folks on rotations have told me, even the folks who've already graduated, who I shared these presentations with, it's stuff that you will most likely reference during clinicals, and I encourage you to. There's a small book that I required last year that I didn't require this year, but it's probably not a bad idea to carry with you on rotations, which, if you like flow sheets, again, I like them. We use a lot of flow sheets back in my day. I don't know how much, square and then line and 2 squares and squares here and squares there, like you follow a path flow sheet. So it has although the type is very small, I had a lot of complaints from those with excuses that they had a lot of trouble seeing it because it was a book about Anyway, I digress. So we'll go through this. I'll stress stuff. If you have questions, write them down, hold them. Hopefully at the end, then we'll have a nice block of time. And then after this, I'll release a very short quiz, which will go over a couple of questions on IV fluids and then a couple of questions on this. So with IV fluids also, and basic electrolyte management, renal physiology is really important, especially with respect to the sodium. So it's probably a good idea to just refresh it, because it will help you grasp this stuff better. The IV fluids electrolyte book, the ridiculously simple book, really, it's a really good tool. And I mean, are you going to get through this course without reading it? Sure. And I just said that, so half of you won't even bother reading. But I'll tell you that it was what I used when I went through this course. I went through this course, I was here. This course, I mean, to be frank, it was very difficult to absorb. It was written, and the expectation was too high a level to really absorb anything. So I said, well, I've got to learn this somehow. And I stumbled across that book, and that book to me was really helpful. So I would encourage you to look at it now and in the future. Today we're going to talk about sodium chloride, CO2, potassium. We're going to concentrate a lot of our time on sodium and on potassium. Toward the end, we'll talk a little bit about CO2, which is a measure that's going to be how you tell somebody has a metabolic acidosis or alkalosis. These on the board here are what is in the basic metabolic panel, the BMP that we order. These will be covered in future lectures. They will concentrate on sodium, potassium, CO2, chloride, very briefly. But derangements in either of the sodium, the potassium, or CO2, especially if unrecognized or mismanaged, can kill your patient. No doubt about it. That's not hyperbole. It absolutely can kill your patient if you don't recognize what's going on. Do you need to know this? No, this is background, but you should know from physiology the importance of electrolytes with respect to muscle function, with respect to cardiac function, especially when you talk about potassium derangements, especially hyperkalemia, if unrecognized and untreated, can cause cardiac arrest. Hypokalemia can also, but the body tolerates hypokalemia better. Sodium, derangements in sodium can cause seizure and death. Derangements in sodium corrected too rapidly can cause brain damage in the subacute term, something called demyelinosis. I forget exactly what it was. But basically, it's something that can take a couple of weeks. You correct it too quickly, and a couple of weeks later, patient's not feeling good, having seizures. Demyelination syndrome. So, why learn it? Well, I just told you, you can kill your patient. Don't let your patient die, and don't tell him. If you screw this up, you know. More background, are you going to get that on it? No. But it really is it's something that should accompany any lecture when you're talking about electrolyte balance. Whenever you see yellow, at least my initial intention when I first built this lecture, these are values that I am asking you to memorize. So that means that for the purposes of the exam, I will not give you a reference range. I will expect that you recognize somebody with hypo or hyper natremic and kalemic. Hypernatremia, hypokalemia. I do expect you to know those by heart. That's why they're yellow. The CO2, you should be able to recognize acidemia, acidosis or alkalosis. But really here, the reason why I say that, why do I say that? Why are you giving me a hard time? Why do I memorize it? Don't I usually get the reference range in lab? Yes. True, yes. Well, let's say you graduate here, you take your first job with me, and you work, and you get a nurse who calls you and says, hey, Bill, the guy in 7, the sodium is 108. To which you say, all right, that's cool, and then you go finish your sandwich and have a cup of coffee and go outside, take a walk, because the weather's nice, because it's, season, it's nice outside. They're not going to tell you that, oh my God, the sodium's 108, what are you going to do? This is really bad. You should probably take it. What's the trend? What's the patient's mental status? They're just going to tell you a value. You might even get a page or a ledge that they sent you a page or something like that. You 9, they never told you the page, but you did. You end up having answers to why you didn't do anything about it. That may or may not have happened to you. But you're really responsible to know these values that you know without somebody telling you it's critical in case you get a phone call rather than a lab slip that has a reference range or the computer more likely. We're talking CO2 or talking bicarb? Well, we're talking CO2, which on the basic metabolic panel is a representation of bicarb. But you don't call it the patient's bicarb. I don't look at a BMP and say bicarb 9. Patient CO2 is 9, but you have to specify. So you specify whether you talk about an ABG, this is not in the context of an ABG. So total CO2 content does correlate with bicarbonate. But on that lab, it's called the CO2. It's not called the bicarbonate. So, and this is again, I'm trying to get you into the mode of where you need to be at least in the beginning. So there are certain labs, again, and I will stress to you when I want you to be familiar with the number without getting a reference range. Anytime you see yellow, you should scrutinize that. Again, wow, you're putting it again on here. It's just very important. You need to know why. Why, doctor? Why? I don't get it. You're pushing me. Why? You're just giving me a hard time. No, Because I had a fellow graduate who graduated and started working with family practice and didn't recognize the critical lab value. So when me and a colleague of mine were talking to her, we're like, huh? Well, what did you do? You did something, right? I think you need to call the office now. You need to call the patient now. Like, you can pass. This is after hours. Failure to recognize the critical lab value. So I am telling you, if you are not graduating this program with the inability to recognize the critical lab value, and then I alluded to the fact that serum CO2 will get to toward the end of the presentation. Serum CO2, which represents bicarbonate, normal range, it depends, I gave you a reference range. It does vary lab to lab to lab. So in my head, 22 to 28 is what I go by, but it depends on what lab is giving you the result. But you should recognize if you're glancing at a BMP and you see highlighted, the CO2 is highlighted at 15, you should recognize immediately, oh, that represents a metabolic acidosis because it's below normal. The bicarb, CO2 correlates with bicarb, is below normal. Something is consuming it, or you're losing bicarb. So maybe it's renal tubular acidosis that you haven't learned about. But you need to recognize it so that you scrutinize it and do something. That's crazy. Why are you pushing? Again, all this push that I'm doing is based on other people's schools, including folks who have two initials at the end of their name without a C at the end. They begin with an M and end with a D. People screw this up. They screw this up all the time. It's good business for us in the ICU, don't get me wrong. But it's bad for the patient. You wouldn't want to be that patient where the clinician doesn't recognize the CO2 of 7 and just lets it go and does nothing about it. So that is a severe metabolic acidosis. Again, requires scrutiny, and we'll talk about at least the beginnings of how you scrutinize the metabolic acidosis at the end of the lecture. We'll start with sodium. We're going to spend a good deal of time with sodium. Again, 135 to 145 milliequivalents per liter is normal reference range. Critical values, I do want you to be familiar with critical values. Those are at least values that, even by themselves, demand immediate scrutiny. But anytime you look at labs, you want to look at a trend. If you look at a trend, that can give you a bit more of a sense of, is this an emergency? Is this something that I can, take a deep breath, look it up, or is it something to address now? That's usually what you need. Well, a serum sodium of 125 is low, right? But not a critical value. However, if the patient's previous serum sodium 8 hours prior was 140, now it's 125, that represents a very, very rapid correction that puts the patient in danger of brain damage. That then you scrutinize it, bless you. You see that you have this trend, you need to reverse it. So what do? If your sodium too rapidly moves in one direction or the other, you have to slow it down or even bring it back. And that has to do with the physiology, how the brain adapts to these changes in sodium, which I haven't looked up recently, so I can't go into further, but that's the problem, is how the brain adapts to these changes in chronicity, these changes in sodium. And that's what causes the ensuing damage. So, briefly, the thing to remember about sodium is that total body sodium, again, this is something I remember that I learned in physiology here. This is physiology. The total body, the concentration of sodium, rather, the concentration, the MEQ per liter, the concentration in bloodstream, does not represent total body sodium. It represents more likely total body water. So if you have somebody who's hypernatremic that's above 145, that implies most likely that they are low, they have a total body water deficit. That makes sense. So they're dry. Putting it more colloquially, if the serum sodium is high, they're probably dry. And that's relatively straightforward. It's pretty rare that somebody will have hypernatremia due to increased intake of sodium. It's possible. But a lot of times, and that's why I've highlighted it in whatever color that is, kind of an orange color. So usually it means you've lost a lot of free water and you're dehydrated. That's often what that represents. Hyponatremia a lot of times ends up being the opposite. It's not usually that someone's low on total body sodium. It can be the case, But the first thing you have to assume is that somebody has increased free water gain. So maybe they lost, maybe somebody who uses sweat profusely and drinks just water. That's that rare case of somebody who really is that active or losing that much sweat and not drinking something with electrolytes. Typically, you find not drinking Gatorade and whatnot, contrary to what they want you to believe. But it is possible with extreme salt loss or sweating that you can become hyponatremic due to increased drinking free water. But other cases, something called psychogenic polydipsia, which is a very fancy way of saying I'm drinking a lot of water on my own for some reason. Sometimes it's just like psychiatric illness. I had patients when I remember when I first graduated, I was interviewing somebody who came in with hyponatremia, and I remembered this, and I said, okay, well, so tell me about your diet. Do you drink a lot of water? Do you feel really like you're thirsty? You have to drink a lot? And I started getting the sense that there was something screwy up there. And she admits that she drank like a pitcher of tea basically every hour or two. So all day drinking tea, and that is what caused her hyponatremia. But it can also be something called SIADH, syndrome of inappropriate antidiuretic hormone, which will cause you to gain free water due to the action of antidiuretic hormone in the kidney. You can also have, and this is important to know because it makes me smile because, again, not even before I did this, I always remembered this. And, I work with some pretty smart folks who every once in a while will get a patient with a blood sugar of 800 or 900, and they have a serum sodium of 126 or I had one recently that was 116. And, this physician X, actually a couple different ones. Oh, no, you gotta keep an eye on it. They start to represent like nothing. I think it'll get better with the sodium alone. I'm like, all right, Dr. So, but, the sugar is 880, so that's factitious hyponatremia. Sodium is probably around 128. It's probably not that bad. Oh, yeah. Oh, no, okay, yeah. Okay, cool. All right, no problem. Disregard. And it happened as recently as last week. And actually, it didn't even think about it. I was working nights and I was listening to it. Oh, wait. Because the sodium had gone up to like 135. So these people from 116 to 135, right about, had an MI. When I looked at it, it was factitious or pseudo-hyponatremia. We'll talk about that briefly. But hyponatremia, it actually turned out, I don't believe it, but apparently it's the most common electrolyte abnormality in hospitalized patients. I thought it'd be a really interesting asking how often you deal with that. But again, the point here is you have to watch, you have to manage it, you have to watch it very carefully, and you do not want a rapid change in that sodium. That is really, that is an exquisitely important concept that I want you to really internalize. You have to remember that. Cerebral osmotic demyelination. And it really, neurologic catastrophe is not hyperbole. Really, if you screw it up and you fail to recognize that and you let them go, it could be a couple of weeks later before they can end up getting symptoms. I've only had one ever that I know of that actually had a diagnosis of cerebral osmotic demyelination from too rapid a change in sodium. A lot of times, I think most commonly, and actually one of my physicians will always say, most commonly this happens with patients with alcohol. Alcoholics with all the free water that they drink, free water with suds, hops and barley and whatnot, and that ice, whatever they end up doing. They will end up, what happens is they wash out the call that in the kidney, the countercurrent system. Did you guys learn about that? That concept is pretty cool. Look it up again and remind me of what it is. I know that that's the mechanism by which you're able to concentrate. Your urine. Maybe it's the opposite. So the point is that folks who drink a lot end up becoming solute poor. And the way you get them, the way you fix them simply is even with normal saline, their sodium will come up and start making urine. But what I want you to take home, low sodium is bad. You want to watch the trend. You don't want to correct it too quickly. Which When do you worry most about hyponatremia? We'll talk about it. So the concept of pseudo-hyponatremia, which I alluded to earlier, so significant hyperglycemia is going to be really, this is the most common way that I see it. In theory, yes, significant hyperproteinemia, significant hyperlipidemia, these are conditions that are going to cause when your blood goes through the analyzer, I guess what it does is it increases, on contact pull from the molecule, it draws water with it, it makes it seem like the concentration of sodium is less. That's the way I understand it. Same concept that happens with the hyperglycemia. If I'm wrong, please someone correct me. But the point is that these other molecules in there are causing a false result. That's like pseudo. They have not actually hyponatremia. Their serum sodium concentration is not actually as low as what is being indicated by the lab. Significant hyperglycemia is when you're going to see it on my examination. I'm not going to look at the other ones, because this is what I see. I see that once every month or two, probably, where it's significant enough where I need to make a statement on the chart saying this is pseudo-hyponatremia. The corrected serum sodium is blank. And yes, I want you to memorize that equation, which is coming up on a subsequent slide. In the future, it's available on your iPhone. There's an app. MedCalc is my favorite. But these patients are not symptomatic at all with respect to the hyponatremia. And there it is. So the measured sodium plus the glucose minus 100 multiplied by 0.016. So that might be, I think that might be the formula that I want you to memorize. So if someone has a serum sodium of, let's make it easy, it's 130, and their glucose is 1100, right? 1100 minus 100 is 1000. 1000 multiplied by 0.16 is going to be 16. So their corrected sodium would be 146. That's how you apply that rule formula. So if you do see it on the test, the math is pretty easy. Probably something similar to that, or you should be able to figure out in your head. But once you're out of here, a lot of things you'll figure out your favorite apps to calculate things. And there are going to be several calculations, especially if you work in acute care medicine, like internal medicine hospitalists, like intensive care. So hyponatremia is usually associated with hypokinesia. So that means that most of the time when you're hyponatremic, your serum osmolality is going to be low. And really, a lot of times these patients are going to have a high amount, they're going to have a higher amount of total body water. They're not usually going to be dehydrated. But I mean, if you consider the chemistry in the blood, the sodium plays a very significant role. So if someone's sodium is low, they're going to be hypotonic because they have low sodium. That happens, I guess, by definition. And a lot of times, like the concept of SIADH, which is really the prototypical hyponatremic patient, it covers pretty well in that little book. It's basically they have continued water intake and they're not peeing out water. This patient, your patient with SIADH, your average patient with hyponatremia is going to present to you with low urine output and a low sodium. And you confirm the etiology through testing of the urine. That's urine osmolality. We test the urine sodium. We'll talk about that. I'll give you what I really want you to know. The next thing is the basic. What's the approach to the patient with hyponatremia? The basic approach. So, etiology. It is not. I do not expect you to memorize all this word for word. I want you to understand the general concept. Usually, really, water gain, excess water gain with respect to your serum sodium. So, kind of like, I'm sure somebody here has drank like Kool-Aid or Tang or something that you have to mix, I used to do that. But you take, so if you take a cup of water and you add something, you add salt to it, right? So let's say that you have the human body, you add salt to a cup of water. So if you add more water, you don't add salt. Have you changed the sodium concentration? No. Have you lost any sodium? No. Not actually. Have you changed the sodium concentration? Yes. Have you lost any sodium? No. But the concentration is going to be lower than it was previously. Let me back up a bit. I almost confused myself. Cup of water, add salt. That's your body. So if you're going to become hyponatremic, one of two things has to happen. Either you're going to lose salt or you're going to gain water. More commonly, you're going to gain water. And you're going to gain water if you're drinking too much and you're not peeing it out fast enough, or if you're just not peeing it out fast enough. If something's wrong in your kidney that's preventing you from urinating. So when's that going to happen? Diuretics interfere with that. SIDH, so unregulated production of antidiuretic hormone, which could be due to cancer. Cancer can do it. And certain medications can also cause SIDH, commonly your SSRIs. I'm not sure if have you learned about SSRIs yet? Depression medication. What is some of the updates? So that's one that immediately, if someone comes in hyponatremic, I'm going to look for what medications are they on. Thiazides and SSRIs are really common causes that we see in the intensive care unit in the hospital, generally speaking. Iatrogenic. So remember, talked a little bit about IV fluid administration, and let's say you really didn't pay attention and you really just forgot all about that. Your patient comes in with serum sodium of 136, and by an hour eventually you'll learn that these ranges 135 to 145, take them to 136. And they're not really eating, so you start IV fluid, and you remember, well, we can start everybody on D5.5 with 20 K, because that's what I've always seen. You start on D5.5. That's a hypotonic fluid. They already have a sodium of 136. Tomorrow we'll have a sodium of 134, 133, 132, keep going down unless you change that IV fluid, because you're giving them hypotonic fluid. The sodium content is about 75 MEq per liter in D5 or in half normal state, right? So if the serum is at 136 and you're giving them 75, you're giving them more water with relation to salt. So that can cause hyponatremia because you're giving them hypotonic fluid. Remember, cup, salt, you're adding water. So you're doing it for the patient. So iatrogenically, you can do it with hypotonic fluid. So what, again, take home, it's water gain. Something's causing water gain. There could be something you're doing. It could be something happening to the patient. So kidney dysfunction can cause them not to urinate, and then you're just gaining water and your sodium is going down. You're overloading the patient. Diuretics cause you to lose sodium. That would be a cause of sodium loss. The book really, I remember the first thing I remember when I read that book was how it talked about diuretics, how they really are a very significant cause of hyponatremia. And it does a good job of explaining that, because it explains it in relation to actually the renal tubule and how the medication works. So again, hyponatremia, water gain, generally speaking. But again, GI losses, especially if you're just nausea, vomiting, diarrhea, and you're just drinking regular water, that can cause hyponatremia because you're losing salt with relation to the water you're drinking. So it's a combination of sodium loss and water gain. Alright, I'll pause for a second. Is anybody completely confused and do I need to go back? Is anybody oh my goodness, I'm just completely lost. Not to use this talking about this crazy. Obviously wired because there's too much coffee this morning. Seriously, anybody really lost? So I'll go back. No. So hyponatremia, water gain or sodium loss. There's concentration. You're talking about the concentration of salt in the bloodstream. So what's going to cause the concentration of the salt in the bloodstream to go down? Other cases here, so edematous states, patients with cirrhosis, heart failure, nephrotic syndrome. Nephrotic syndrome and cirrhosis, you have low amounts of protein in the blood. Ends up very edematous. You just end up not peeing out water because it just all kind of builds up in your body. You're just not staying in the bloodstream. Two things that are part of the workup of hyponatremia that you have to remember. When you have somebody who's hyponatremic, they come in the hospital, they come in your office, or you're following up labs. Two things you got to order are a TSH, that's a thyroid stimulating hormone level, and cortisol level. Again, it will come up on a future slide. But it's because hypothyroidism and adrenal insufficiency are two significant causes of hyponatremia that are very easy to rule out. It's part of your workup. Remember I told you before, urine sodium, urine osmolality. To that you add a TSH and a random serum cortisol. Because those are two causes. Beer potomania, which is just a cool way to say someone just drinks and doesn't really eat anything. so they end up having low solute load. They just kind of wash out from the kidneys that countercurrent mechanism. That's funny. That's what causes the hyponatremia. I've got to look it up. If you don't remember, look it up. I got to look it up. But I'm just telling you, that's the mechanism behind beer potomania and why that causes hyponatremia. We see this a lot. We see it a lot. Sadly, there are a lot of people out there who drink like, I don't know how they do it, 8 a day, 24 beers a day. Like I literally laugh at it. How do you do that? It's just like, you can't stop doing it. Pounding down beers like you're in college all day long, every day, forever, but you're not in college. Sure. Yep. I mean, so you're right. The serum cortisol has a circadian rhythm to it, if you will. But what you're looking for is an extremely low level. And when you take it, the lab will give you a reference range saying at 6 a.m. this, and at 3 p.m. whatever this. So you do want to pay attention to when it was drawn, but at the same time, I'm really looking for something that is really, really low, where there's no question. If it's equivocal, then you can do further testing for adrenal insufficiency. But for the purposes of at least your beginning of knowledge, if you're looking for something that's like no question about it, it's very low. So that's a good point. So this is just a slide talk about beer potomania. So, and these patients who do this, who don't eat solute and just take in free water basically, will end up with a chronic hyponatremia. So chronic versus acute. Briefly stop on and mention that. A chronic hyponatremia is very well tolerated, generally asymptomatic. You'll have somebody walking around, I've had a sodium of 105 and walk around just like, hey, how's it going? I'm not feeling so well. It's really tough. Acutely, if somebody has a sodium of 105, they'll be seizing. They'll be having seizures right in front of you. They're not going to stop. But 105 chronic, they can walk around and be okay. So it's important to know whether it's chronic or acute. And you'll know basically by how the patient presents. And of course, taking a history. SIADH, SSRIs, thiazide diuretics, beer potomania can be somebody with chronic hyponatremia, patients with cirrhosis, which is of course, end-stage liver disease, patients with chronic and fully controlled heart failure. These are all patients who could walk around with low sodiums to varying degrees on a chronic basis because of their underlying condition. So clinical manifestations. This is important because the treatment of hyponatremia will depend on the patient's symptoms. And this is important because it's just important. So, if a patient comes to you asymptomatic, then the initial treatment really is to stop. You restrict their fluids and you order the test by the sodium. To try to really investigate it, you order serial serum sodium every 4 hours, every 6 hours. You keep checking serum sodium because you want to check the trend. You don't want it to go anywhere. You want to see what happens if you just restrict fluids. If your patient has psychogenic polydipsia and you restrict fluids, they're just going to get better on their own. They're going to start peeing all that free water. They're going to stop drinking as much as they're drinking. They'll start urinating some, and they should begin to get better. But a reasonable first step in hyponatremia is to restrict fluids or stop all fluids and investigate with the TSH, serum cortisol, urine osmolality, urine sodium. Patient comes in altered mental status or seizing. So especially seizing, I've considered severe hyponatremia, severe symptoms of hyponatremia. Those patients are the ones who get 3%, which is hypertonic saline, to begin to actively raise the serum sodium. If someone is seizing and they're not stopping seizing and they're hyponatremic under 120, that's a medical emergency. They end up getting a bolus, so they end up getting a larger amount at once of 3% sodium chloride solution, in an effort to rapidly raise the serum sodium to a level of 120. Now, I won't dwell on that too much. I do want you to understand that. I want you to be familiar if you saw a situation in terms of what the patient needs. But more likely than not, that's not going to be your responsibility depending on what you end up doing. Once you have familiar with what the patient needs, you know to look it up. Because chances are, if a PA or physician who's not ER or ICU or nephrology tries to order a bolus of 3%, the pharmacy is going to be like, no, you can't do that. Did you call the intensive doctors and nephrology doctors? Down to what you do. It goes beyond the scope really of general medicine. But I want you to be familiar with that's what the patient needs. Seizing, severe hyponatremia, you've got to get that serum sodium up to 120 rapidly. They're altered, confused, or maybe even lethargic. 3% as an infusion, not as a bolus, to bring them up. If they're asymptomatic, you pause and try to investigate what's going on. And I gave you the initial workup. Sure. Blood. So it's, yeah, so you would order it, and typically when you order labs, you should order them like before the nurse initially draws. In the ER, they'll just draw like a tube of everything, so they're usually can anticipate what you're going to want, or at least they're just going to draw one of everything because they know that most of the common tests will come from the 4 or 5 tubes that they normally draw. But these tests that I talked about, the urine, the urine osmolality and urine sodium are for the urine. But the other stuff, the TSH and the cortisol or blood, the basic metabolic panel, which is what initially gave you the hyponatremia, again, that's blood. So it's going to be frequent blood testing that this patient with hyponatremia will require, again, to check the trend. You want to make sure that it's not going up too rapidly or not getting worse. So that has neurologic implications. Again, this is one of the topics that is covered in fluid and electrolyte. So history, again, try to figure out why, and do ask. Do you drink a lot of water or tea? Are you always thirsty? Anorexia, again, this is a patient. Maybe it's not neoprotomania. Maybe it really is somebody who's just not eating, and all they're doing is having hot water with lemon every day. I had a friend once I used to make fun of. I said, "Yeah, what do you have to watch? A bowl of tea?" And she was a little. She didn't really. He's not in front of people. So, if you want to look at fluids, what IV fluids is the patient getting? What medications is the patient getting? Are they getting an SSRI? Are they getting a thiazide diuretic? Those are only the 2 initial ones that you should think of. Fluid output, ostomy, drains, urine, how much urine. If they're hyponatremic, you would expect them not to be urinating very much. If they're urinating a lot and they're hyponatremic, it's probably because either IV fluids that you're giving them or because they drink. So stop that. And if they keep urinating, that sodium will come up. And that's a good thing to keep in mind. This is a nephrologist who clued me into this. You can tell the sodium is starting to rise by the patient's urine. If they're beginning to urinate a great deal, scrutinize the sodium level, probably coming up. So if you have a patient who wasn't urinating, and you give them pills, or you give them sodium chloride tablets, where you encourage them literally to, tell them, give them a few bags of Lay's potato chips, give them solute. If we believe that solute depletion, like your neoprotomania, your anorexic, your tea and toast diet, if they start to urinate copious amounts, stop what you're doing, check the sodium. Again, you do not want that to rapidly rise. The only time it's acceptable to rapidly rise is if it rapidly fell. So if you have a patient who was 145 yesterday, and today they're 125, it is okay in the same period of time to get them back up to 140, 145. It's the only time that it's okay to get them back up rapidly. If it's chronic, you don't do that. It's bad for the brain. The brain gets angry. So, one thing I hadn't mentioned, you want to check the volume status of your patient. And really, it's euvolema versus hypervolemia. And that'll clue you in if they're hypervolemic, if they have edema and they have heart failure and they have cirrhosis. That clues you into that fact that they're fluid overloaded because of that disease state, and that's probably the reason for the hyponatremia. And if you optimize treatment to that, you can fix it. Otherwise, if they're euvolemic, you got to think about things like SIADH. And I'm not going to go over really encroaches, I'm trying to really keep this a 2-credit course, because it encroaches on some of my theory and more advanced concepts if I go down a tangent of how you treat each individual one. But at least my job is to tell you how to look at them and how to work them up and where to go. But definitely the one thing I don't want you to forget, a lot of people do, is at least that beginning workup and what you're looking for. We'll talk about in the subsequent slides the urine sodium and osmolality, what you're looking for. Here we go. So TSH, if your TSH is high, that's hypothyroidism, you fix that and you'll fix the sodium. If your serum cortisol is low, that is adrenal insufficiency, you fix that, you fix your hyponatremia. Both of those are causes of hyponatremia. You treat the underlying cause, you'll get that serum sodium back up. If the serum sodium is excessively low and they have open metal status, 3% saline. If they're asymptomatic, you don't necessarily have to give the patient 3% saline. Infusion. Some nephrologists might use a serum sodium of 120 as a cutoff. If they're below 120, they might get 3%. To get them above 120. If it's above 120, they'll probably just leave them alone and kind of monitor and see maybe they give normal saline, or sometimes they'll give oral sodium chloride to get that sodium level up. The urine osmolality. So this is a measure. So forget about, we'll talk about numbers. I say forget about it for a second, but so that you can visualize it. You don't have to memorize anything. So if someone's urine osmolality is 50 milliosmoles per liter, and I'm not really sure the body can, I don't know that it's even that low. If you look at the urine, what is it going to look like? Yes, it's pure water. If it's 1,200 milliosmoles per liter, it's going to be very concentrated. So, if your patient's serum sodium, your patient's serum sodium is low, if they have hyponatremia, and their urine is very concentrated, does it make sense that they have hyponatremia because they're inappropriately concentrating their urine? That's the concept. That's the concept behind something like SIADH. That's why they're hyponatremic. So, serum sodium level is low, so they have too much body water. They have too much body water, they're not peeing it out. And the way you can tell that initially is check the urine osmolality. If it's inappropriately concentrated, that's the cause of the hyponatremia, and you got to figure out why. And SIADH is one of the initial considerations. Leave it there, because I'm telling you, it's a 2-hour lecture. SIADH by itself is a 2 to 4 hour lecture. If the urine osmolality is low, so if it's below 100, if the urine is water, and they're hyponatremic, as I described before, maybe it's psychogenic polydipsia. It's the patient doing it to themselves because of compulsion. Obsessive compulsive. Some folks like that, like I have got to have 16 glasses of water before lunch. Or tea, or whatever. So, the urine osmolality is one way to try to break down what's going on, what's causing it. Again, if their urine is water, which is appropriate, then wait to see what happens. If it continues to correct, then it's because the patient is drinking too much on their own. Because otherwise, it just doesn't make sense. Physiologically, it doesn't make sense. The patient, something's happening that's causing that sodium to go down, even as his body is trying to correct it. So the patient himself is sabotaging it by drinking sodium. Does that make sense? That makes sense. Somebody walks. I'm not sure if it's just you're bored or you're tired. I just like some cases that are kind of blank, but if anybody understands what it's like to be tired and overloaded, I get it. Sorry, it's not. I'm trying to make it interesting. So serum sodium. SIADH. So let's say you have you're not sure if it's syndrome of inappropriate antidiuretic hormones. So the patient has a spot in their lung, maybe they might have lung cancer. They have lung cancer. You get your urine osmolality, and it ends up being high. So they're inappropriately concentrated. You check the urine sodium. If that is also high, about 40 roughly, SIADH, they have your diagnosis. That's the likely cause. If it's under 20, it's a little bit more up in the air, and it can be. But then you got to think about something like heart failure, cirrhosis, nephrotic symptoms. I assure you that on the exam, I'm not going to make it. It's not going to be extremely complicated. Because I could look at it if I wanted. I'll try to come up with some cases to clarify this a bit better. But otherwise, the two things you look at are serum sodium, serum osmolality. Hyponatremia, TSH normal, cortisol normal, urine osmolality high. If the urine sodium is high, that's ideal. If the urine sodium is low, then you have to kind of keep looking further to investigate what's going on. This is where like that decision tree would be helpful. Alright, getting past that. What do? I talked about it. They need to be hospitalized, especially if it's low. It's mildly low. It's 134, 133. I don't know that I'd worry about it too much. If it's in the 120, that patient belongs in the hospital. Certainly if it's under 120, that's critically low. Serial serum sodium. Q4 hours, every 4 hours, every 6 hours is reasonable. And at the same time, you are checking serial urine osmolality and urine sodium. That's what the nephrologist and some of them will like to do, because that helps guide treatment. Because ultimately, in order to treat that, the osmolality, the tonicity of what you're giving them, has to exceed that of the urine, or you're not going to make any progress. That's for your patient with SIADH. If your patient is, if it's something else, if it's like they're beer drinkers or something, they'll get better just by giving them salt, because that's the initial problem. Is that they don't have enough salt in their kidneys really for that countercurrent mechanism. Other important concepts, and I've stressed this, and I do want you to remember, avoid rapid correction. The change should not be more than about 8 to 10, roughly, no more than really 12 MEQ in 24 hours. So not more than a change of 0.5 MEQ per hour in the serum sodium. If you're checking serum sodium, it's 112, and 4 hours later it's 114, and 4 hours later it's 116, and it's 118, and it's 120. You catch my drift. You want to watch a slow rise. You don't want serum sodium of 110 followed by serum sodium of 122 4 hours later. That should cause alarm. It's seriously, it's not hyperbole, it's not exaggeration. If you see that, you need to stop what you're doing and that needs to be addressed. At very least, if you have a hospitalized patient and you check in the labs and you come in and you see that change, the first question to the nurse has to be, is nephrology involved? Hopefully, usually they're the ones who manage it. But someone needs to be aware, if not, you need to change IV fluid. If their sodium went up too rapidly, even if, let's say, it went from 110 to 117 in 4 hours, that's too rapid, I would put that patient, let's say they started out on normal saline, I would put them on D5W. I'd put them on water. I want that to come back. I want it to slow down. Because if not, central pontine demyelinosis can occur. Sure.
We're still going to rapidly correct it to 120 if there's seizing.
Yes, that's the only time. If there's seizing, then you get it up to 120 as fast as you can. If they're seizing and they're not stopping seizing, that's rare. I've one time maybe in 6 years I've seen that. Usually there's some sort of alteration in mental status, lethargy, but seizing is not very common. If you do see that, you bolus them with 3% scale. ER should be doing that, or critical care should be doing that, or nephrology. A reasonable goal, if you are getting 3%, is to get them to 120 to 125, and generally stop. We don't keep the 3% going longer than that, because you risk correcting them too rapidly. You want to get them into a safe range. Above 120 is no longer critical. So hyponatremia, get me. You want a hypotonic fluid, yeah. So your choice is going to depend on really, for lack of a better way to put it, what you feel is right for the patient. It's difficult for me to say that you're always going to put them on D5W. We don't always do that. It really depends on how quick is it going up and your experience with it. And if you don't have experience with this, you need to find something to do. Until end up doing this, if you end up working in internal medicine in the hospital, and you deal with this, then you can really tinker with it. Otherwise, at very least, my goal is to get you to realize what's dangerous, what the goal should be, what you're looking for, and what at least should cause alarm is how you're stopping what's coming up. And then to refer back to this if you really do start looking at this. So there'll be some preceptors who will hammer this and want you to know this, especially pediatric ICU. They always make the students do a presentation. So hyponatremia. Why is it happening? Your initial labs, urine sodium, urine osmolality, TSH, cortisol. Stop IV fluids, fluid restrictions, see what's going on, check a trend. Is the patient starting to urinate on their own? What's their history? Do they drink? What medications are they on? Are they having nausea, vomiting, diarrhea, fluid losses? That's a reasonable, that's what I would want you, if I asked you, what do you do for hyponatremia? That's what I'd want you to tell me immediately. Serum sodium too low, hospitalize them, check serum sodium levels serially, Q4 hours, Q6 hours is okay. Altered mental status, 3% saline. Seizing, not stopping, bold. Not seizing, 3% saline infusion to get them up to about 120 to 125. Correcting them, rapidly in 0.5 per hour to avoid rapid correction. That, I could have just said that, we could have done all this in about 5 minutes. But ultimately, that's what I expect out of it. That's what I expect out of all this stuff. But still, just provide some background. It's still less than what you truly need to know if you're dealing with hospitalized patients all the time. But at least this is the beginnings of how to look at and how to treat hyponatremia. And we talked about this. And yeah, it's important. I may include this on the final, maybe not. I don't know. We'll see. But again, this is one of the ways to kill or prevent the death of this person. And we'll talk about this. And hyponatremia. All right, we still got a whole crap on the slide. Take 5. That's 5 minutes, and we'll